You are so warmly welcome to this metal education session, and we are really honored to have an incredible session this evening on latest advances in hemophilia A. Before we begin, it's really important that we share our disclosures with you, and I'm just going to bring those up on screen just now. We have got an incredible piece of education for you today, and we're going to cover some really important topics. Here are our learning objectives. We're going to learn how to initiate timely prophylaxis in patients with mild to moderate hemophilia A to prevent joint deterioration. We're going to learn how to personalize hemophilia A treatment based on bleeding phenotype, activity level, and lifestyle. And we're going to learn how to implement practical approaches for monitoring joint health in patients with non-severe hemophilia A. But before we start our education at Metal, we like to see where you're at the moment. So we do some polls, and we've got some cases that we would love to hear your thoughts on before we dive into the education. So what I'm going to do is I'm going to bring up some cases, and as the audience, I would really love to hear your thoughts. And we're going to cover each of these topics as we work through our education today. So if you don't know the answer now, don't worry, all will become clear as we work through the education. So the first poll is this. A 4-year-old boy is diagnosed with moderate hemophilia A with a baseline factor VIII level of 1.5%. He is very active, but has not yet experienced a joint bleed. His parents are very concerned about his future joint health, and they ask you about preventative strategies during their visit to the Hemophilia Treatment Center. Based on the data and recommendations, what is the most appropriate counsel regarding prophylaxis? A, B, C, D, or E? If you can share your thoughts, that would be great. Thank you for sharing your thoughts. Perfect. I'll give you a few seconds just to do that. Thanks, everyone. If you're just joining us, we're doing some polls. We're hearing your thoughts on some clinical cases before we dive in, and we're going to cover each of these topics as we work through our education today. So I'll give you a few seconds just to share your thoughts in those polls. Thanks, everyone. You're really warmly welcome, and we hope you find this a really helpful piece of education. Okay, I'm going to move on to the second poll. And the second poll is this. A 9-year-old with hemophilia A factor 8% presents to your clinic. He recently sustained his first significant joint bleed in his right ankle after a fall during his basketball game, which required 2 doses of factor concentrate. He's now fully recovered. He's otherwise healthy and wishes to continue playing sports. His parents are unsure about the best path forward for his treatment. What is the most appropriate long-term management strategy for this patient? A, B, C, D, or E? I'll give you a second just to answer that and have a read of the options. If you're just joining us, you can share your thoughts in the poll. You can scroll up to do that in the chat on the right-hand side of the event. If you're on Metal, if you're on mobile, just click the little chat icon at the bottom and then scroll up and you'll be able to see all of the polls. If you're joining us across some of our other platforms, you've got to join on Metal next time and then you can participate in the polls. Okay, the next poll is this one. A 17-year-old male with severe hemophilia A without inhibitors has a history of poor adherence to his intravenous EHL factor VIII prophylaxis regimen, which he's supposed to administer twice weekly. He cites difficulty with venous access and the overall burden of infusions as major barriers. He is now showing early signs of synovitis in his elbows. According to the treatment personalization framework, which of the following options would be the most suitable to discuss with him to address his specific challenges? A, B, C, D, or E? It'd be great if you could share your thoughts in the poll. Thanks, everyone. Super. Okay, thanks for sharing your thoughts. If you're just joining us, you can answer all of the polls on the right-hand side of the event. You just go to the chat box, scroll up. You'll be able to pop an answer into each of those. If you're joining on one of the other channels, one of our social channels, you've got to join on Medal next time, and you'll be able to participate in the polls. Okay, next one is this. A 35-year-old with moderate hemophilia A, factor VIII 3%, is on a PK-guided prophylaxis regimen with an EHL factor VIII product infusing every 4 days. He works as a landscaper and reports that he experiences breakthrough ankle pain and stiffness on the 3rd and 4th days of his infusion, especially after physically demanding days. His most recent pharmacokinetic assessment confirms that his factor VIII trough levels are dropping to less than 2% in the 24 hours prior to his next scheduled dose. What is the most appropriate next step to optimize his therapy based on PK concepts? A, B, C, D, or E? I'll give you a second just to read. And we're going to work through each of these. So if you're not sure of the answer, don't worry. You can hopefully pick it up from what we're about to work through. So thanks for sharing your thoughts. We do this because it helps begin to make us think about the clinical application of some of this information, and hopefully puts it in context as well. So thank you for participating. Okay, we've got 2 polls left. The next one is this. A 28-year-old patient with non-severe hemophilia A, factor VIII 20%, undergoes his annual comprehensive evaluation. His physical exam is unremarkable, with a hemophilia joint health score of 0 for swelling in all assessed joints. However, he reports vague, intermittent ankle discomfort. You're concerned about subclinical joint changes. Based on the evidence presented, which imaging modality is most likely to detect early synovial cartilaginous pathology in this patient despite the absence of clinical swelling? And for those of you who aren't sure, we actually sent out a little pre-read with some information, so hopefully that's quite helpful. We'll give you a few seconds just to answer that. Great, thanks everyone. If you haven't been able to answer all of our polls, if you've just joined us, you can scroll up in the chat on the right-hand side, and you'll be able to pop an answer into all of them. So don't worry, if you're just joining, you can still participate. Okay, final case is this one. I'm just going to bring it up on your screen right now. During a routine visit, a 42-year-old male with moderate hemophilia A, factor VIII 4%, who is treated episodically, reports new onset of persistent spongy swelling in his left knee for the past 8 months. He cannot recall a specific injury. Your HJHS assessment reveals a swelling score of 2, a duration of swelling score of 1, mild crepitus on motion, and a 10-degree flexion loss compared to the contralateral knee. Integrating these findings, what is the most critical immediate step in his multidisciplinary care plan? A, B, C, D, or E? If you could share your thoughts, that would be great. And then we're going to do some very quick rapid fire confidence, because I'd love to know how you found that. How confident are you? Thank you for answering those polls. You've still got time. If you're just joining us, you can scroll up on the right-hand side of the event, and in the chat box, you'll find all of our polls, and you can pop an answer into each of those. Okay, 3 very quick confidence polls, and then we're going to dive into some incredible education today. Okay, it's this. How confident are you in your ability to initiate timely prophylaxis in patients with mild to moderate hemophilia A to prevent joint deterioration? Not confident at all, right up to very confident. Just give you a little second. Thanks, everybody. Great, we're going to work through these real quick. Okay, great, thank you. The next one is this. How confident are you in your ability to personalize hemophilia A treatment based on bleeding phenotype, activity level, and lifestyle? 1, not confident at all. 5, very confident. If you can share your thoughts, that would be great. And then finally, how confident are you in your ability to implement practical approaches for monitoring joint health in patients with non-severe hemophilia A? 1, not confident at all, up to 5, very confident. If you could let us know your thoughts, that would be super. Okay, great. Thanks, everybody, and thanks for participating in all of those polls. If you're not sure of some of those answers, you don't feel super confident, don't worry. That's why we're here today. So we're going to dive into some incredible education, and it gives me really great pleasure to introduce our speakers for today. I'm just going to bring them up on screen. And we're really honored to have Professor Guy Young, who's the director of the Hemostasis and Thrombosis Center and Clinical Coagulation Laboratory at the Children's Hospital Los Angeles. He's also the professor of pediatrics at the Keck School of Medicine of USC. And we also have Susan Knight, who's a physical therapist, and she also works at the Children's Hospital Los Angeles Hemostasis and Thrombosis Center. And we're really honored to have real experts in hemophilia and joint care who will be sharing with us this evening. So I'm just going to hand over to our first speaker, who is Professor Guy Young, and he's going to be sharing about initiating timely prophylaxis in patients with mild to moderate hemophilia A to prevent joint deterioration, and also personalizing hemophilia A treatment based on bleeding phenotype, activity level, and lifestyle. We're also going to have some time for questions with Professor Young and Susan at the end of this session. So please pop any questions you have into the chat on Medal or across any of our social platforms, and we will pose those to our incredible speakers this evening. I'm going to hand straight over to Professor Young.
Hello, my name is Guy Young, and you see my titles there, and I'm here to talk to you about prophylaxis in mild and moderate hemophilia A. I think a subject that has been not discussed enough, especially considering the data we have as well as the new treatments that we have. So we'll be going through all of that next. First and important, here are some disclosures. You can see here disclosures with companies that produce medications for hemophilia. In the second part, we will be discussing some of those medications. In the first part, we will not be discussing any medications, but I won't be discussing any non-FDA approved uses of any of the medications. And then, this continuing education activity is managed and accredited by Affinity CE in collaboration with Medal, and you can read, I think, the rest of the disclosure. I'll just leave up there momentarily. And then finally, and importantly, is that monetary support for this activity was provided by Bayer in the form of an independent medical education grant. And so with that, we can get started. So we have two modules. The first one has the following learning objective: initiating timely prophylaxis in patients with mild to moderate hemophilia A to prevent joint deterioration. So that's what we're going to be discussing. So really, the first question is, why do we use prophylaxis in hemophilia at all? I mean, what actually is the purpose of it? And while it seems like a simple question, I think it's more nuanced and layered than most people imagine. But for this short presentation, I'm just going to essentially walk you through really what the main objective is. So patients with hemophilia are at risk for bleeding really anywhere in their body, but in particular, something unique about hemophilia is the recurrent joint bleeding events. And here's just one picture. As I think you can quite well appreciate, a large bleed in this patient's left knee. If you're looking at the screen, so obviously the knee that's on your right, I don't think it needs any more description than that. And it's not that, we can't treat this joint bleed. We can, and we did. But what can happen is, if bleeds continue to recur in one joint, is we get to this situation. This is something called synovitis. This is not a joint bleed, albeit the joint looks swollen. I will tell you that this boy had no pain, and he walked into this seminar that we were doing, or this workshop we were doing, and he didn't have any pain at all. And here's one more picture of a different boy in the same situation. And when you press on this, it really feels spongy. It feels like one of those, soft sort of dish sponges, if you will. And this was not an active bleed, but this is the result of recurring bleeds in the same joint, which leads to inflammation of the synovium, which is the lining of the joint, which then leads to more bleeding in the joint, which leads to more inflammation, and you enter this vicious circle of bleeding, inflammation, bleeding, inflammation, and ultimately you can end up in a situation like what this boy has. And if we take this further down the line, we end up in this situation with what we call end-stage arthropathy or end-stage hemophilic arthropathy. If you look at this boy's right knee, I think you can very well appreciate that you can't see any of the landmarks. So if you look on the other knee, you can see the kneecap or the patella, and you could see the medial condyle, which is the lower part of the thigh bone or the femur. But if you look at the other knee, the one that's on your left or his right knee, you can't see the kneecap. You can't see the typical bony landmarks. And then if you look below the knee, look at the two legs. I think you'll appreciate that there's a lot of muscular atrophy underneath that damaged knee joint. And that's because those muscles aren't being used, because when your knee can't straighten any more than this, and that's the most he could straighten his knee or extend his knee, you can't walk. And if you can't walk, you're not going to use your calf muscles. So really, what is the purpose of prophylaxis? Is to avoid this final situation. But of course, we want to do more than that. We want to avoid any bleeds at all, if possible, to improve patients' quality of life. So who gets prescribed prophylaxis? Well, I mean, typically in countries that are well-resourced, like the United States and other countries around the world that are well-resourced, patients with severe hemophilia, it's essentially an automatic that if you have severe hemophilia, you should be prescribed prophylaxis, probably from a very early time in life. Well, not probably, definitely from an early time in life. And starting prophylaxis early in life has been proven that without prophylaxis, you will develop permanent joint damage, the pictures that I showed you. So prophylaxis does go a long way towards preventing the what you saw in those images that I showed you. Now, in general, most moderate, not all, but most moderate and all mild hemophilia patients really do not start prophylaxis from a young age at this point in time. I say most moderates because there are some moderates that are around 1%, and they will have a bleeding pattern typically similar to severe hemophilia. So there are moderate hemophilia patients that will start prophylaxis early, but that's a very small group of them, and typically just the ones that are around 1% as their baseline factor VIII level. So I guess the discussion then is, why is it that we're not starting moderate and mild hemophilia patients on prophylaxis early? I think partly it is a misconception that these patients don't bleed. I mean, they don't bleed as much as a severe patient, for sure, but the notion that they don't bleed, that they don't get joint bleeds, and they don't get permanent joint damage, I think that is a misconception. And as we have better and better medications, I think that the idea of starting prophylaxis in moderate and mild patients is very, very important. The second issue is the cost. And yes, it is very costly to use prophylaxis, but we cannot use that as an excuse not to treat patients who really should be on prophylaxis. So let's take a look at some data on moderate and mild hemophilia with respect to bleeding. And I'm going to show you 3 different studies, all of which are fairly recent. In fact, this is the oldest study I'll show you, and it's from 2022. So obviously, this is not an old study, published by a Dutch group, and looking at the title, The Bleeding Phenotype in People with Non-Severe Hemophilia. And I'm going to just show you a few figures and walk you through their data. So on the figure on the left, here we're looking at, I say for both of these figures, we're looking at the age at the first bleed. So any bleed, but the age at the first bleed. The figure on the left is moderate versus mild, moderate in red and mild in blue. And then figure B on the right side, I'm going to walk you through that in a second. So let's focus on the figure on the left. Again, moderate in red, mild in blue. And I just put an arrow here. So that looks like approximately 2, maybe 3 years of age. And what you'll notice is that 50%, so that's the incidence on the y-axis, that half of the patients with moderate hemophilia, and this is all moderate hemophilia, not just those with 1%, but half of them will experience their first bleed by the time they're around 2 to 3 years of age. If we take all the mild hemophilia patients together, about a third of them will experience their first bleed by the time they're 10 years of age. But when it comes to mild hemophilia, it's a very broad category. It includes levels of above 5% up to 40%. So it's a really wide-ranging group. So if we break down the mild hemophilia group further, as we are in the figure on the right side, we're going to break them down into those whose baseline factor VIII level is 0.05 to 0.15, so 5 to 15%. In green, 15 to 25%. And then those of, sort of the mildest of the milds, if I can say that, is greater than 25%. So if we break down the milds into those three groups, now we see something a little bit different in the sense that the milds at 5 to 15%, so the lowest end of mild hemophilia, now you can see that half of those patients are going to experience their first joint bleed by around 8 years of age. So we can't think of mild hemophilia as one large group. In fact, probably not even moderate hemophilia as one large group. And I will show you data from other studies that break this down further. Now, looking at the incidence of joint bleeding, what is the age at first joint bleed? Same figures as I showed you before, but this is for joint bleeds. So if we look here, by the age of 10, patients with moderate, half the patients, or a bit more than half, are going to experience a joint bleed by the age of 10, while they're still relatively young children. Again, this is all the moderates combined. And about a quarter of the patients with mild hemophilia, by the time they're about 13, 14, are going to experience a joint bleed. And again, breaking down the mild hemophilia as we did in the previous figure, if we look at those at the lowest end of mild, at 5 to 15%, you can see that about 20% of them, by the age of about, looks like 6 years, are going to have a joint bleed by the age of 6. So 1 out of 5 will have a joint bleed by the age of 6. And then one last figure from this paper. And I think what's important here, we're looking at annualized bleeding rate on the left. So total bleeds per year, basically annualized bleeding rate, the calculation of that. On the right is annualized joint bleeding rate. That's what the J is for in the other figure. And I just want to point out an inflection point. So you can see roughly here, maybe a little bit higher than this point, there's an inflection point where the line tilts sharply higher. And it's around 10%. Maybe I could move the arrow slightly to the right, maybe closer to 15%. But you can see that as you get below about 10, maybe 12, maybe 15%, that the annualized bleeding rate starts to increase significantly. But there's a very clear inflection point in this other figure right there, right at 10%. And this is where joint bleeds begin to increase substantially. Now, keep in mind, this is annual joint bleeds per year. And so even if we're looking at a level at around of those around 5%, so just to the left of that arrow of 0.2 or 0.3, we're talking about one joint bleed every 3 years, which means throughout your childhood, 5, 6 joint bleeds. And as I showed you in the previous figure, it doesn't take that many joint bleeds. Actually, I didn't mention that, but it doesn't take that many joint bleeds to lead to the damage that I showed you. So we really want to have joint bleeds really at 0. I mean, that's really the goal. Let's take a look at this other study. This is from a European group, mostly it's an Austrian group, looking at bleeding phenotype in non-severe hemophilia, looking at a few different parameters. So first, this is looking at a slightly different set of data. So at the top, figure A is total bleeds in the last 5 years. And at the bottom is joint bleeds in the last 5 years. So let's walk you through this. This is based on the lowest factor activity level. So based on their lowest levels, how they categorize the patients. And this is the probability. So the yellow line is greater or equal to 1. So at least one bleed in the last 5 years. And what you can take away from this figure at that point is that as your factor level goes down, the likelihood is you're going to have more than one bleed every 5 years. But I think even more important is this part, which is more than 5, or at least 5, greater or equal to 5 bleeds per over 5 years, which means one bleed per year on average. And you can see as you get down to about 10%, the probability is about 20%. As you get down to 5%, it's about 25% of having at least a bleed per year. And that's kind of the point I'm making here. If we take the 3% line, half of those patients are going to have at least one bleed in the last 5 years, and about 30%, and this is at 3%, the midpoint of moderate hemophilia, you're going to have at least 5 bleeds over the last 5 years. If we look at joint bleeds, it's the same kind of figure, but now we're just looking at joint bleeds. If I draw the arrow again, just at 3% as an example, a quarter of patients will have at least one joint bleed in the last 5 years, and about 15% are going to have at least 5 joint bleeds, and that's for patients at a level of 3%. So again, this figure is essentially saying that the lower your factor level is, even in the mild hemophilia range and in the moderate hemophilia range, you're going to have more and more bleeds, and you're going to have more and more joint bleeds. They also looked at the Hemophilia Joint Health Score, which is a scoring system designed to assess joint disease. And any score more than 1 means there is some joint disease. So that's why they kind of made this figure as greater or equal to 1. Only 0. A score of 0 means no joint disease. And really, you're seeing the same kind of figure here, where as you get lower factor levels, the likelihood of having a hemophilia joint health score greater than 1, greater or equal to 1, rises sharply. And so if we just draw the line at 5% here, which is sort of the border between the moderate hemophilia at the highest end and mild hemophilia at the lowest end, you can see 60% of the patients are going to have a joint health score that is greater or equal to 1. And that's greater or equal to 1. Many of these are going to be substantially higher than 1. So finally, this last paper, looking at bleeding phenotype according to factor level in a large group of patients, 825 children with non-severe hemophilia from a European group. So this breaks down the hemophilia groupings a little bit more. So here we're looking at age at first joint bleed in hemophilia A patients. The y-axis is the cumulative incidence. And then we have the breakdown here. So we have moderates on the lower end of 1 to 2%, moderates on the higher end of moderate at 3 to 5%, and then 4 groupings of mild, 6 to 10%, 11 to 15, 16 to 20, and 21 to 25. And so if I draw your attention to this line, this is the 50% line, because it says cumulative percentage without a joint bleed, so it's a little bit of a reverse. But if I draw the line here at half, you can look at it as cumulative percentage without or cumulative percentage with a joint bleed, because I put the line at 50%. So if we take a 5-year-old, any 5-year-old, you can see that if you have moderate hemophilia and you're 1 to 2%, you have a 50% likelihood of already having had a joint bleed by the age of 5. And of course, once you have one joint bleed, there's going to be more and more to follow. So that's why this age at first joint bleed is important, because it's a harbinger of things to come. If we look at the moderate hemophilias at 3 to 5% in the purple line, now to get to the half cumulative incidence, it's 7 years. So even those who are 3 to 5%, who mostly are not on prophylaxis these days, by the time they're age 7, they are likely to have, they have a 50% likelihood of having a joint bleed. And finally, just the mild hemophilia patients, if we draw the line here, we're drawing the line at the 6 to 10%, so the lowest end of mild. Half of those patients will have a joint bleed by the age of 10. So mild hemophilia is not immune from joint bleeds. And this is a figure looking at the annualized bleeding rate. It's similar to the figure I showed you earlier, looking at all bleeds in yellow, joint bleeds in purple. I didn't put any animation on here, but I think you can appreciate the inflection point. Again, around 6 to 10%, or maybe slightly lower for joint bleeds, where the incidence of joint bleeds begins to increase dramatically once you're below 6 to 10%. So mind you here, we don't even have severe hemophilia on this scale. Severe would be all the way on the left at 1%. This is just looking at moderate and mild hemophilia, and you can see at the different levels. So what do we make of the data? So I think hopefully proven to you that patients with moderate and mild hemophilia do develop joint bleeds. Those with the lower factor levels will develop joint bleeds at a younger age. And as I showed you in the pictures, that joint bleeds, it doesn't matter if you have mild or moderate hemophilia. If you have joint bleeds, especially recurring joint bleeds, that's going to lead to permanent damage. And those with joint bleeds that are overt probably also have subclinical joint bleeds. In other words, joint bleeds that don't rise to the level of having symptoms, which are also going to be damaging to their joints. So what do we do with this data? You need to recognize that patients with mild and moderate hemophilia A will all develop joint bleeds at some point, and mostly in their childhood. And understand that those with the lowest levels, like 1 to 2% moderate hemophilia, will likely have their first joint bleed at a young age, before the age of 5. And so it's important to follow these patients closely early in life. I would say at least every 6 months, with careful joint assessments. When to start prophylaxis? I mean, definitely no later than after the first joint bleed. So if you want to wait until the first joint bleed in these patients, I think that's okay. But I mean, once they've had one joint bleed, I think that's the trigger, and you need to start prophylaxis. Of course, you can do that before the first joint bleed, and that really is a shared decision-making discussion that I'll show you in a little bit when we talk about the different drugs. For patients levels greater than 2%, I think it's reasonable for them, it's reasonable to wait for them to present with their first joint bleed, because for some of these, it won't be until they're 5 or 10 years of age, and for those who are milder, with hemophilia, it might be even closer to 10 years of age. And so I think it is for those patients greater than 2% at baseline to wait until there's a joint bleed. And like I said, you may spare them many years of prophylaxis and start when they're older. They're more able to comply with the treatment. It's easier for the parents to administer the treatment. So those are my thoughts. Those are really, my opinions about that. So take-home messages for this module: severe hemophilia A patients should all be on prophylaxis. And that's not the subject really of this discussion, but I wanted to make that point. And that moderate and mild hemophilia patients should be assessed frequently, especially early in life, to determine their bleeding phenotype. And once a joint bleed occurs, or you could do it before the first joint bleed in moderate hemophilia. I'm not saying you have to wait for the first joint bleed, but definitely after the first joint bleed, prophylaxis should be started. And current standard of care must consider all the patients with hemophilia A, regardless of their severity level for prophylaxis. So I'm going to move to module 2. This will be a bit shorter. This is about personalizing hemophilia A treatment. And so there are more and more treatment options for hemophilia A. I mean, now we have factor replacement therapies, and we've got several different categories of those, 3 actually. We have non-factor therapies for hemophilia A, and we also have gene therapy. So how do you choose what's the right treatment for each patient? So just a brief overview, because it's a short module. We don't have time to get into the nitty-gritty details, but just one sort of comparative slide here is looking at the drug's mechanism of action and infusions per year. So factor replacement can be once a week in hemophilia A, or it can even be every other day. So that's where I show you it's 52 to 183 infusions per year, and it's only IV. Then we have the factor VIII mimetics, of which only emicizumab is licensed. Those are weekly to every 4 weeks, so 13 to 52, and those are subcutaneous. And then the rebalancing agents, all of which were just recently licensed: fitusiran, concizumab, and marstacimab. And you can see the frequency of their dosing. I won't read it off. Those are also all subcutaneous. And then there's gene therapy, which is infusions per year. Well, it's only 1 infusion period, not per year. It is IV, but just 1 dose, with the goal of hopefully not needing to be on prophylaxis after that. So I kind of use analogies. So the treatment options for the last few decades, until we've had these newer treatments, was just factor replacement. And all the factor replacements essentially work the same. So I kind of equate that to Subway, where the only food you can leave there with is essentially a sub, and there's some different options of what you might put inside, which is kind of the analogy of the slight differentiations of factor. But now we're in the Cheesecake Factory era, where you've got a menu that's multiple pages, and where you can have any kind of food you want, from salad to pasta to steak to vegetarian to everything. So how do we choose? Well, we use a shared decision-making model. This is one model which uses the acronym SHARE, where you're going to seek your patient's participation. You're going to help your patient explore and compare treatment options. So you're going to educate them about the different options, sort of like the slide I showed you before, although you'll need more detail than that to really discuss the options. Then you assess your patient's values and preferences, and I'll show you some thoughts about that on the upcoming slides. And then you reach a decision. You say, okay, well, with your patient together, we decided we're going to go with medication A. But then the important part is you have to evaluate your decision. So see the patient back in 3 months or 6 months. How are things going? And if they're not going well, then certainly you can change and go back to a different treatment option and go through the same cycle again. So what are the patient categories? Well, I break it down like this. By age, less than 12, 12 to 18, and greater than 18. I break it down like this because we currently have several non-factor therapies that are approved only for patients older than 12. So you have to keep that in mind. Also greater than 18, because gene therapy is only approved for greater than 18. Of course, there's hemophilia A and B, although today we're really focusing on hemophilia A. There's the different severities, which we've already discussed in the previous module. And then inhibitor status. That's important because some medications can be used for patients with inhibitors and some cannot. But it goes beyond that. What about other things? And this is where you're assessing your patient through that shared decision making by asking them, how is your venous access? Are you able to access your veins? If it's poor venous access, then an IV therapy is not going to be a good idea for them. That's where some of these decisions come in. What about their adherence? Are they good or poorly adherent? You might decide on a medication that's given less frequently as something that maybe would be better for adherence for patients, although some people argue that it might be better to do something more frequent because then patients won't forget. So again, thinking about the adherence and what the barriers to adherence are. Or is the patient risk averse? I mean, are they, yeah, I kind of like to stick with my conservative principles in terms of treatment. I kind of like to stick with things that have been around for a long time. Or is the patient not risk averse? Like, no, no, I'll take, give me what the latest treatment, the latest best treatment. I don't care if it hasn't been out for that long. So that's another category. And then lifestyle of work or play. Do they have a high risk job, or do they do high risk sports, for example? Or are they sedentary? That might come into your decision making. Other categories come into the age of elderly versus not elderly. So greater than 65 being sort of the cutoff for elderly. Apologize if those of you older than 65 don't consider yourself elderly. That's fine. But the point here it really is that the risk for thrombosis goes up as you get older. And so this is where you might consider issues related to that. What about their joint disease and bleed history? Is this somebody who's had a lot of joint disease, a lot of joint damage, or no? Because that might figure into your decision making. And then finally, the patient's own values. Are they wanting the treatment that has the highest possible efficacy? What's going to make them the highest likely not to bleed at all? Or are they willing to occasionally have a bleed, but they want the lowest treatment burden because they hate treating? So, there's not necessarily a trade-off. I mean, I've put it here as like you have to do a trade-off of high efficacy versus low treatment burden. There are treatments that are efficacious that have a low treatment burden, but in some situations, there can be some trade-off here as well. So those are other things to consider. And then what about pharmacokinetics to individualize factor therapy? So we really only have data on that. And I'll just show you a little bit of data on using a tailored PK-guided approach to prophylaxis, which can maximize outcomes while minimizing factor utilization. And there's lots and lots of studies on this, but we don't have enough time to get into all of it. So just briefly looking here at extended half-life factor VIII in the light blue bars versus standard half-life. So extended half-life can be dosed about every 3 days, maybe every 4 days, whereas standard half-life is really every other day is the best treatment. And you can kind of see the sort of this theorized PK going up and down. And then non-factor therapies, you can see at the bottom NFR. We know that with the non-factor therapies, at least, well, I should say with emicizumab, which has been around the longest, those patients are probably living around 10 to 15%. I don't think we really know with some of the newer products where patients are living. So that's the non-factor therapy. So here's an example. And what we're showing you here is this happens to be cogenate on the left side, which is one of the standard half-life factor VIIIs, and then Jivi, an extended half-life factor VIII on the right. And this is looking at 3 different subjects, like in theorized subjects. So here's a poor PK subject. So that, in other words, they metabolize the drug fairly quickly. And so here the dosing is Monday, Thursday dosing, and you can see where their levels will end up. But if this, but with Jivi, which is an extended half-life factor VIII, you can see that the levels are substantially higher. Notice that with the poor PK subject, you're going below 1% at the trough levels on the left, and with the EHL, even a poor PK subject, you're staying above 1% with Jivi. Here we have a normal PK subject where you're dropping close to 1%, but maybe not below 1% on a twice-a-week schedule. Whereas with a normal PK subject, you're staying probably much above 5%. On the lower end. This is a logarithmic scale. And if you have a good PK subject, they might do fine with a standard half-life drug like cogenate, not dropping much below 10% between doses. And if it's a good PK subject, they may stay above 20% if you're using an extended half-life factor VIII. So this is where, doing PK assessments for patients on factor therapies, you can make choices and decisions, and it's definitely recommended to do this to maximize the outcome, as I said earlier, as well as minimize the number of doses that need to be given. So another way of thinking about it is adapting treatment by age. So on the top here, I talk about which bleed control issues are sort of the highlights of the different age groups. And on the bottom, the administration mode. So intracranial hemorrhage, this is a serious concern, particularly in the first year of life. 2 to 5, this is the toddlers. They're always falling, biting their tongue, falling on their head. This is the accident period time. 6 to 12, this is when school, obviously people are in school, away from their parents, doing crazy stuff at recess or PE, and kids start playing sports or more intensively sports at this age. Teenagers, well, they may do sports and they like to do high-risk activities. We know teenagers like to take risks. And at greater than 18, sports may still be involved, and now high-risk jobs like construction, for example, might be part of somebody's lifestyle. In the youngest age group, subcutaneous is really an advantage because it is hard to do IV therapy. And for those who really need recurrent IV therapy, you need a port, right? You need a central venous access device, which is something we try to avoid. So subcutaneous administration is really most valuable, I would say, in the youngest of ages. Not that it's not valuable for older ones, but most valuable at that age. As you get to the school age kids and the teenage kids, well, subcutaneous is still easier, but accessing veins becomes definitely easier at this time. And for those greater than 18, they have the option of subcutaneous therapies, IV therapy, or potentially gene therapy as well. So what drugs are available? Well, for subcutaneous at this age, the only thing we have available is emicizumab for hemophilia A, because the other drugs that have recently been approved are only approved for older than 12. For this age group, we have emicizumab. We can do IV with factor VIII concentrates, and for those older than 12, marstacimab, concizumab, and fitusiran are all also licensed for those patients. And if we take it out to the adults, we can now add gene therapy as well. So you can see that the choices really start to increase as we increase in age as well, although that will change as drugs like marstacimab, concizumab, and fitusiran become available for younger children less than 12. That we're probably 1 to 3 years away from all of those being available for that age group. So my take-home message is individualizing hemophilia A treatment is very important, and that implies understanding the way that the treatments are given, their risks, their benefits. And so the best treatment option, for example, at one stage of life, like infancy, may not be the best treatment option later in life. So for example, early in life, subcutaneous is the most important because we want to start treatment early. We don't have to deal with injecting or accessing veins or with ports. But if we get to teenagers who may be playing sports or doing high-risk activity, that's where factor therapy may become the best option. So I think you have to consider your treatments across the lifespan of patients. For those who are on factor VIII prophylaxis, I would consider all the different options. You have standard half-life, extended half-life, and an ultra-extended half-life factor option. And one might be right for one patient, another might be right for the treatment. And then finally, using a shared decision-making, which you probably are already doing, but really thinking through it a little bit more carefully, and ensuring that your patients have input into the treatments that are ultimately chosen for them is really important. So using that to determine which treatment option is best, and then revisiting that decision at each clinic visit is important. So hopefully this was informative for you and that you learned something. And I really emphasize from the first part to really think about mild and moderate hemophilia A patients for prophylaxis. You probably haven't thought about it very much, like I haven't either, but now is the time to really start considering that with all the treatment options we have. And with that, I'll stop and thank you for listening.
So as alluded, you'll be able to claim a CME certificate at the end of this session, and we'll be sharing the link with you right at the end. Professor Young, thank you so much for an incredible piece of education. And it gives me great pleasure to introduce our next speaker, who is Susan Knight. Susan is a physical therapist, and she's going to be sharing practical approaches for monitoring joint health in patients with non-severe hemophilia A. I'm going to hand over to Susan.
I'm really humbled to be here to speak to you today. These are my disclosures. I'm speaking about the last objective for this session, which is I'm going to be talking about the importance of monitoring joint health in patients with non-severe hemophilia. We're going to look at why it is important, even in the absence of overt bleeding signs. We're going to talk about physical exam, patient-reported outcomes, and imaging to detect early signs of joint bleeding. And lastly, we want to talk about how to integrate joint health monitoring into a multidisciplinary care plan and how that is the most ideal standard of care for patients with hemophilia of all severities. So why should we do joint surveillance in non-severe hemophilia? Hemophilia is a disease that produces joint disease in light of even one joint bleed in the lifetime of a patient. This is a well-established fact, and we want to do our best to try to prevent this process from even starting. The patient's joint will deteriorate over a long period of time, which is one issue in making it difficult to study. But we want to try to preserve on the screen there, a normal joint, so that they can have the best outcomes. What initially happens is that the joint begins to bleed. So looking on the right side of the slide is blood is introduced into the joint, and there's like a hypervascularization inside the joint. Then the synovium becomes inflamed, it becomes hypertrophied, and you begin to get synovial changes. That's like the first stage. Then after that, the blood that stays in there has that affinity for cartilage, then the cartilage is at risk initially for deterioration. There's also some fibrosis in the joint. That's what sort of contributes to the range of motion issues that we're going to talk about. And these changes, are the second level of changes. And then once that the final issue is more what we typically see with patients with arthritis is they develop the bony changes, so the cyst and the osteoporosis. So I like to divide this into short and long-term effects of joint bleeding. And again, just to emphasize, this happens over years. And, so this is why this long-term monitoring is necessary to make adjustments in the patient's care to prevent joint bleeding and prevent progression if there has been joint bleeding. So you see on the left side of your slide, there are short-term effects in this, very healthy knee in the first picture on the left. And then blood enters the joint, as we were talking about on the previous slide. And then there's this swelling state. So if we're at the state of seeing swelling, there is a problem because we know that means that there is blood likely in that joint. And the longer it stays there, the worse are the problems. The long-term effects, you can see on the right side of your slide, is that as that swelling can become permanent. And then, as we talked about, over time, it can lead to wearing away of the bone. And in worst case scenarios, and definitely what we're trying to prevent in this day and age with the products that we have to manage this disease, is that we want to prevent this permanent damage. So the next few slides just give us some visuals. I think this is, if you've been taking care of patients with hemophilia for a long time, this is something that we don't see typically in patients, especially on prophylaxis anymore. But I think it's a good reminder that we need to keep vigilant, even in our patients with non-severe hemophilia. So this is what a patient would present with. They even might be more flexed at the knee depending on the acuity of the hemarthrosis. This is that synovitis, that sort of boggy cantaloupe size joint. If the inflammation, if they're late to get factor replacement treatment, this can persist, and this is often painless. And then ultimately end-stage arthropathy, and we're hoping, hopefully, none of our patients are, being treated now, are going to be at this stage. But we have several patients that are in adulthood that do have these types of changes, and it really impacts their activity and participation in life. So we want to talk about severe hemophilia and how bleeding presents, and then mild and moderate hemophilia, so the non-severe hemophilia. So in severe hemophilia, they can present, as many of you know, with spontaneous bleeding, injuries, and there's clinical symptoms. You can usually locate that on a clinical exam, and it can usually confirm joint bleeding. Not all the time, but there's usually some correlation. And but I think we have to think about, many of our severe patients are on prophylaxis, on non-factor products as well. And it's sort of, it's created the patient, at a level of non-severe hemophilia, keeping their levels steady. So I think even more so a reason to think about these considerations of monitoring patients with more mild or moderate hemophilia. And I think this is where things get gray. If there's an injury, often a patient will not stop participating in their activities. Their symptoms can be tolerable. There can be a level of underreporting, which leads to delayed care. And often when they come in, the clinical exam can be inconclusive without adding in specific imaging. And then there's this issue of subclinical bleeding. When the clinical exam, maybe on an annual comprehensive visit, is not it's not really showing any clinical signs. Okay. So I want to take a minute to look at the most recent papers that support this joint surveillance and close joint surveillance in patients with mild or moderate hemophilia. The last systematic review on this was done in 2011, and I think it really speaks to the changes we have seen in the use of point of care ultrasound, and now that we're seeing, using that more frequently in our clinics, we're able to kind of see what is a little bit more information about what is subclinical bleeding. So this first article was an MRI study looking primarily at adults, and the major finding is that even without patients, without report of bleeding, I think out of 51 subjects, 19 of these patients had moderate hemophilia, 32 had mild hemophilia, and they had all low annual bleeding rates. Almost were zero. And a total in this cohort of 51 patients with non-severe hemophilia, there were only 12 lifetime bleeds in the moderate patients and 1 bleed reported in their lifetime in a mild patient. So I think that, even in light of that, there were clinical signs of hemosiderin, especially in the ankles. So paying really close attention to all the joints, the elbows, the knees, and the ankles is really important. There were some comments in this study about, we have to also consider all these studies actually here are done on adults, and, there is a level of development of arthritis that occurs with age and some age-related changes, which they noticed more could be conflicting with the knee involvement of patients. But again, most of the involvement was in the ankles. Another study out of Spain looked at using the ultrasound and the head US protocol for assessing joints, and in combination with the HJHS. This is a cross-sectional multi-center study, and in this study, ultrasound detected early joint changes in a notable proportion, like 50% of the patients, despite not having any recorded joint bleeds. And in the last study, this one was more of a prospective cohort, just looking specifically at patients with moderate hemophilia. This was done in Italy, and all these patients were on demand. There were 51 subjects, and they found the common, joint pathology was common, and it was variable, and 21.6 of these patients had osteochondral damage. And they offered some ideas in terms of like a practical model for integrating point of care ultrasound in follow-up visits. Okay, so how do we make clinical decisions on what to do with these patients when they come to a hemophilia treatment center? I think as a physical therapist in the center, I just want to offer these practical tips in terms of interviewing the patients with mild and moderate hemophilia. I think kind of being open and curious about any report of musculoskeletal injuries or pains. And it's usually not a one question situation. I feel like I go in and then I start working with the patient, and then something evolves, or I'll find a large scratch, where there was like a scar or something, and I'll start to dig and ask about that event. And then they'll say, oh, for 2 weeks, I, had trouble walking, or, they just kind of thought, like it just kind of healed. And so I think it's attuning the patients and attuning yourself to some of these subtle reports that they may not think could present with bleeding inside the joint. Ask if they've had any participation or activity changes in the last 6 to 12 months. There are some tools, that patients can report their activity and participation levels in, if that's something your clinic or that would work in your clinic flow. As well as, I think, just stressing a lot of communication with families and reminding them that they could call the center with any questions when their kid or their adult has a musculoskeletal injury. That is really key, that communication with the treatment center. These are well established. The Hemophilia Joint Health Score is the gold standard in terms of assessing joints in patients with hemophilia of all severities. I'm going to go into that in a second here. And then imaging, we want to look at, these are the types of imaging we have available. And I think the key point here is like what imaging is detecting early joint disease. So MRI has been a very long-standing gold standard, but there are challenges in getting patients MRIs, and it can't be immediate. So that clinical decisions sometimes are slowed, but a very good option at looking at these early or subclinical bleeding. Ultrasound has definitely in the last 10 to 15 years become more of a mainstay in hemophilia treatment centers, using point of care ultrasound, determining if bleeding or not bleeding, using different protocols, the head US as well as the JADE. With the head US, definitely detecting early arthropathy, and with the JADE looking more at early and late arthropathy, but both able to determine, early signs of early joint disease, which is that changes in the synovium. And then X-ray is definitely something that issues show up there in later joint disease, or if they're having an acute bleed, definitely you would be able to see some general swelling and distension. These are the areas of the HJHS in hemophilia treatment centers, typically performed by a physical therapist. But I want to highlight for anybody evaluating, doing a clinical exam on a patient with hemophilia, that there are many areas that can be done, and that can contribute to your clinical reasoning in deciding, is this patient at risk for either bleeding or subclinical bleeding. So swelling and duration of swelling, which I'm going to highlight on the next slide. Muscle atrophy is something always comparing side to side. Crepitus, joint pain, global gait is definitely watching the patient walk, run, hop on one foot, going up and down stairs. And range of motion and strength, there's a specific way, and there's a specific way to learn to do this, to actually calculate a score on this assessment. Like I said, usually done by the physical therapist. But let's take a deeper dive on swelling and duration of swelling, because that is potentially like our one clinical sign that we can evaluate without any tools except for our hands and our eyes. So when looking at swelling, you really, as this picture depicts, is you really want to get your hands on the key joints, so the ankles, elbows, and knees, and want to palpate around the front, around the back, and compare to the other side. And you're looking for this slight bit of puffiness. And then, more visual signs would be, if they had more visual signs, would be bony landmarks would be obscured partially or completely as it gets more severe. And you also want to have a good pulse on the duration of the swelling and how long it's been there, because that's going to tell us something about how long this problem's been going on. And then we have the ability to use point of care ultrasound. And this is pretty well established. There's many courses on this, and many physical therapists and physicians and nurse practitioners are using this in their clinics. And you can see the outline in the purple in the right ankle that's typically what bleeding looks like in the joint. The yellow area is the tailor dome. So this is the ankle, and you can see how it's kind of pushed down, and the space is filled with blood, essentially. So I think this is where we're at in terms of assessing joint health in patients with hemophilia. Is the gold standard is that there is good correlation between using the HJHS and ultrasound. And in this particular article, ultrasound was found to find synovitis in 40% of cases that were assessed where no swelling was picked up on the HJHS. And I think this is really it can sound like, oh, we should just do ultrasound. And I think this would be a great discussion point at the end of this talk, is that I think there needs to be a combination. And because there are things that ultrasound doesn't necessarily consider, and that is some of the strength issues, some of the pain issues, some of the gait issues. And like we always think about, we're not an image, but I think there is really high value in using ultrasound in combination, so that for these times that we don't pick up on anything in the clinical exam, we can lean and be really confirmed and have more accuracy, so that we can ultimately provide accurate, personalized management to each patient that we see. And overall, we want to integrate this into multidisciplinary care plans. And that may look differently if you're at a hemophilia treatment center versus whether you're in primary care. And I think there's a role for, everybody's input. And I've had the fortunate ability to work in a multidisciplinary hemophilia treatment center for a couple decades, and I think there's just a lot of value that everybody brings to the table. And I think the one thing for primary care, if your primary care physician, is to really think about making sure your patient has some connection to a hemophilia treatment center, and that you could be examining their elbows, knees, and ankles for that presence of swelling, and just responding to every report of injury and asking those kind of further questions, and also to refer more quickly for imaging when symptoms or history, are suspect for bleeding. And the National Bleeding Disorder, the NBDF Foundation, is an excellent resource for finding those hemophilia treatment centers in the United States. So in summary, non-severe hemophilia does not mean that you're risk-free. Joint damage and changes can be frequent, despite minimal to no reports of bleeding episodes. And kind of moving away from bleeding count leading our exploration and clinical assessment of the patient, that we need to really consider imaging to detect this early damage. I think there's a lot of questions still out there, and frequency and protocols for this, especially to a lot of the studies are completed in adults, and we need to think about children and what sort of monitoring we would do for them. And then lastly, I think the biggest takeaway is that, that we have to use in combination the HJHS, plus imaging to be considered with all severities of hemophilia. These are my references.
Wow, fantastic session. Thank you so much, Susan, for walking us through evaluating joint health in such great detail. I'm just going to pull up QR code. So if you are joining us and you need to leave early, please scan that QR code and give us some feedback. It's really important to us. It helps us to keep improving. Importantly, it allows you to claim your CME certificate for joining us for the last hour as well. So that's really important. Please scan that. We'll pop the link in the chat as well. Okay, we have an opportunity to ask our experts some questions, and thank you for giving us some of your questions. Professor Young, Susan, thank you so much for joining us and for such wonderful presentations and for taking some questions. Perhaps I might start with you, Dr. Young. You suggested that for patients with factor levels of greater than 2%, it's reasonable to wait for the first overt joint bleed to initiate prophylaxis. However, Ms. Knight's just presented compelling data on subclinical joint damage being common and detectable via ultrasound, even in the absence of reported bleeds. How do we reconcile those 2 points in practice? Should evidence of synovitis on a routine surveillance ultrasound without a patient-reported bleed now be considered a primary trigger for initiating prophylaxis, for instance?
Yeah, no, that's thank you for the question and the kind words, and it's great to work with Susan on this program and with you all as well. Yeah, no, it's an excellent point. I think that, the target, or I should say the sort of the goalposts keep shifting for prophylaxis. And I think they're going to continue to shift as we have drugs that are just easier to administer, particularly subcutaneous and particularly less and less often. And so I think, the point I was making was more based on the published data, which suggests that patients above 2%, so the 3 to 5% moderates, may not have a joint bleed until age 5 or age 7. And so the question then does become, what is the um, practical implications of deciding to start prophylaxis before the first joint bleed? And one of those is the fact that not all joint bleeds are overt, as Susan has pointed out, and as we know from other literature about subclinical bleeding. And so, is there or are there small microscopic bleeds that are not giving any symptoms, what we call subclinical or asymptomatic bleeding, or some people call microbleeding? I don't love that term per se, but is that happening in patients who have a factor VIII level of 3% or 4% or 5%? And I think the short answer to that is we don't really know. And so I think the decision to start prophylaxis in somebody at the range of 3 to 5%, again, I always come back to shared decision making, because there may be parents of children that age who are going to want to push for starting prophylaxis with a subcutaneous drug that, perhaps one that can be administered once a month or every 2 months, to minimize the burden. And I always listen to the parents, and I know that they've given it a lot of thought before they even introduce a once a month needle injection to a young child. So I think all that needs to be taken into consideration, and the fact that the goalposts are shifting. And so whatever the lessons are from today, a year from now, if we do the same discussion, I might have a different discussion point in my talk. But I think the answer is that I was stating that from the data that we have available on patients that are 3 to 5%. So just recall those figures about at what age we tend to see joint bleeds, which is typically, on average at the age of 5 or 7. So in some patients, it could be younger, in some patients, it could be older. So that's what needs to be, that's kind of where my thoughts came from. I would never fault anybody for starting prophylaxis at a younger age for somebody even at a higher factor level like 3, 4, 5%. Some of that is going to come down to the payers, and will they agree to pay for these expensive drugs? And that's a whole nother discussion that we won't get into today, since this is really more about the academic part.
Sure. Ms. Knight, I wonder whether we could discuss ultrasound, and you kind of pointed to it in your presentation that it's it's becoming an important tool, and the argument for integrating point of care ultrasound, or POCUS, is very strong. And beyond the initial cost of that device, I'm interested in your experience from a training perspective as well. What are the most significant real world barriers to implementing a routine POCUS program in a busy hemophilia treatment center? And maybe you could comment on the challenges related to training, credentialing, integrating that into the workflow for the multidisciplinary team.
Yes. So yeah, I think it really can depend on your, a few things. I mean, the training is not a huge barrier because there are resources to do training specific to hemophilia. And any professional that works, especially in a hemophilia treatment center, can get trained in terms of like a nurse practitioner, a physician, a PT. In most hemophilia treatment centers, the PT takes this on. And what I see is, there is a challenge in the sense of some hemophilia treatment centers are more freestanding and have, you have this ability to sort of control your clinic flow a little bit more. And, because these taking these images takes time for a patient coming to the clinic, they're seeing multiple disciplines and to carve out time to do this. It is challenging, on the fly as you're moving through many patients in clinic. But I think if you, kind of focus where you want, what you want to answer, what types of questions you want to answer. And that is one way to kind of, then, have a better sense of how you want to integrate this into your program. So we're more focused on, more point of care, and we're going to be, mostly looking for, bleeding or not bleeding symptoms and those early changes, working in a children's hospital. But I think, every center has to kind of figure this out and figure out how it's going to work in their clinic flow.
Got a really interesting question here, perhaps for you, Dr. Young. And you talked about the balance between frequency of intervention to remind you that you still got to do this, and the power of that frequency versus the benefit to the patient of reducing that number of interventions. And a key differentiator, this is the question, a key differentiator is the reduced infusion frequency, potentially decreasing from that 156 infusions per year with an every other day SHL regimen to 104 or fewer with an EHL product. In your experience, how significant is the reduction in treatment burden on long-term adherence and quality of life, particularly for young children or patients with difficult venous access?
Yeah, so the question we have to divide into the IV and the subcutaneous therapies. When it comes to the IV therapies, so every other day is about 186 infusions a year. Twice a week is 104. And then once a week would be 52. So I just use, parents of the patients we take care of often fill me with really interesting quotes. And so I still remember this one mom, she had two boys with hemophilia. At the time, they were probably 7 and 5, and this is well before the introduction of Hemlibra or emicizumab. And I brought up the idea of an extended half-life Factor VIII, and she was not one to jump to new things very often. But when I explained it to her that way, and so she basically said, one less infusion per week. Is that what you're saying, Dr. Young? I said, yes. And she said, so that's for each of my boys. And I said, yes. So she said, so that's a total of 104 less infusions a year that I have to do. And I said, yes, your math is correct. And her response was, wow, that's huge. That's a lot of a burden off of me, even though there's still quite a lot of infusions to do. So, everybody takes it differently. And this is why I think the shared decision making always comes back, because my job is to explain to patients, explain to parents what their treatment options are, be it IV, be it subcutaneous, be it however frequent it might be, and with the associated lab tests that might be needed. And then with the family and or the patient, we can then collectively make a decision on what works best for them from the standpoint of both the treatment burden as well as the potential efficacy. And that's really the only way to come to a solution. I will tell you that for the subcutaneous drugs, right, we have one now that is daily. We have one that is weekly. We have one that is either weekly every 2 weeks or every 4 weeks, and then one that starts off every 2 months. So they're really very, very different. And yet, you would think every patient would want the least frequent, but that's actually not the case. I've had patients tell me that a daily injection is what I prefer because this way I won't forget. It's something I do every day. I brush my teeth every day. I do my injection every day. Easy to remember. And then the other patients say, well, I hate doing injections. I hate the needles. Whatever is the least often, and I will remember it. I'll put it on my calendar. I'll put it on my phone. I'll put a reminder. So, we have to remember that hemophilia patients are people, and the parents of patients are parents like parents of other children, and they may have different views of the different treatment options. So I think it's imperative on us as treaters to educate our patients about all the different options, the strengths and weaknesses of each, whether it's IV or subcutaneous, whether it's frequent or less frequent. And then collectively, you can make the best decision because it's not always the most obvious thing. So the most obvious thing might be, oh, I think for me, I would want to do the least number of injections, but that's not always what patients want. So your job is to inform them of the options, work them through the different options, and then collectively make the decision that they're happy with and that you're happy with.
Couldn't have put it better. It's a really great reminder that this is all about the patient and those conversations. And perhaps I think we've got time for one last question. I'm gonna pose it to you, Ms. Knight, and it's this: the ultimate goal of prophylaxis is shifting from simply preventing bleeds to preserving long-term joint health. How do we best communicate this evolving goal to our patients and families, especially those with non-severe hemophilia who may feel their condition doesn't warrant lifelong proactive therapy?
And it's a hard question to answer, but I think getting them to come into clinic, bringing them into clinic, reminding them of, what we're trying to do by optimizing their treatment and personalizing their treatment so that, they have the best chance to, have a life that's like free of these long-term consequences. And just making ourselves incredibly available, for them to reach out in between their clinic visits, which, for a mild or moderate patient may be, probably at most twice a year, depending on, their issues. And for a mild patient, it may only be once a year. So really, making those relationships that they have a place that they can come to and we can provide this education and teaching. And you really, honestly, we're talking about a lot of our severe patients with severe hemophilia now that are, less bleeding less than they're more behaving like our patients with mild and moderate hemophilia. So also thinking about it for those patients as well.
Ms. Knight, Professor Young, that is all we have time for. I just want to say a huge thank you from us, from everyone who's joined us today, for answering so many questions and a really wonderful, practical and patient-focused piece of education. Thank you so much.
Thank you. Take care.
Thank you.
To those of you who are joining us, I'm just going to pull up the QR code on the screen. If you'd like to claim your CME certificate, you just need to scan that QR code. We've popped a link into the chat on Medall. You can access it on the right-hand side of your screen, or just click the little chat icon on the bottom of your screen if you're on mobile, and the link is in there. That will allow you to give us a little bit of feedback. It will also, importantly, allow you to claim your CME or CE certificate. So scan that code, click on the link, give us some feedback, claim your CME certificate for free. If it's the first time you've joined us today, you've been so warmly welcome. I hope you find this education really helpful, really practical, and I hope that it will help you in your day-to-day clinical practice. We run lots of education. It's always open access. It's always free. We're really passionate about making it helpful for colleagues, and I hope that you've certainly found this helpful today. It's certainly been a pleasure having you here today, and I hope we'll see you at another Medall CME session sometime soon. Thank you.